I think Ansar Rai's talk is extremely important, demonstrating that physiology can trump time, can trump a lot of the other clinical factors that I'll be talking about. However, to be fair, there are folks who do not agree with the concept that CT perfusion can give accurate enough information to select patients. The physiology that he's describing is indicating who has gone on to complete their infarct based on a lot of the clinical and anatomic factors that I'll be talking about here. So the gist of my talk is how to select for success, and you need to define what is success for you. Is it helping the most people? Is it hurting the fewest people? And unfortunately, you can't have both. If you're going to be aggressive and take risks to help the most people, you're also going to be hurting more people too. And if you're just starting out in a program, you're doing something new, you know that you need to select patients who are more likely to do well. When you're talking about intra-arterial stroke interventions, it's an unusual field to be working in where no matter how good you are, you will have probably fewer than half the patients that you treat who get better, who do well. And a lot of the patients will have intracranial bleeds and die and do horribly. So if you're not selecting your patients for success, you do run the risk of having your program be discontinued because of outcomes that are not acceptable to your community. I think the first question in terms of selecting for success is, should you be selecting anybody to treat? And we've talked a little bit about the three recent trials that were published in the New England Journal of Medicine, MR Rescue, IMS3, and Synthesis Expansion. And the bottom line for those three trials is that they all showed no benefit from intra-arterial therapy. There are problems with these trials, and the SIR will be publishing an editorial to address some of those problems, but three negative trials in the same issue of the New England Journal of Medicine carry some gravitas and have an effect in the stroke community. Some of the problems is that they used very few second-generation devices. They included patients who did not have the disease that we treat. They didn't have large vessel clots, so you wouldn't expect them to get better from a treatment that dissolves or removes large vessel clot. They had poor rates of complete or near complete revascularization. If you don't get the artery open, you don't get a good result. It took them a long time to treat the patients, and if you've already got a completed infarct, by the time you revascularize the artery, you're not going to do any good, but you will be doing harm. And therefore, in several of these studies, they selected patients who would either do well or do poorly,